Hello everybody. Today we are going to discuss about nutritional scoring in the ICU. In critically ill patient, normal nutritional status plays a key role in overcoming critical illness and is closely associated with clinical outcome. Early phase of critical illness is characterized by the severe catabolic response to mobilize nutrition reserve from the muscle and the adipose tissue. The catabolic process is further increased by several pro-inflammatory cytokines like tumor necrosis factor alpha, interleukin 1, and interleukin 6, leading to the rapid loss of lean body mass, muscle wasting, and predispose critically in patient to high risk of malnutrition. Malnutrition in the critically ill patient is associated with increased infectious morbidity, multiple organ dysfunction, increased length of stay, and increased mortality. Nutritional status declines very rapidly in the intensive care unit, even in well-nourished patients. Some patients may lose up to 2 kg of the protein in first 10 days of the ICU stay, in spite of adequate calorie and the protein intake. ICU patients lose twice the amount of the protein as compared to the healthy individual. A malnourished case in the ICU definitely needs nutritional support, but well-nourished patient in ICU also needs nutritional support to prevent malnutrition. Nutrition maintains the homeostasis in the critically ill. The provision of early and the adequate nutrition preserve the lean body mass and support the patient during acute stress period of increased catabolism and metabolic instability. Nutrition therapy also decreases the metabolic response to the stress and prevent the oxidative cellular injury and modulate the immune response. Early enteral nutrition support reduces the severity of the disease, decreases the infectious complication, reduces length of stay in ICU, and improves patient outcome. Now, nutritional assessment tool, subjective global assessment. Subjective global assessment was initially developed by Detsky et al. In early 1980 to predict the post-operative outcome. So SJ is a simple, harmless, and the inexpensive time saving and can be used at bedside by any healthcare professional to detect the patient with high nutritional risk. It is validated tool based on the history clinical examination, which incorporate clinical history, physical examination. Clinical history include weight loss history, dietary intake changes, GI symptom persist for more than 2 weeks, functional capacity. Physical examination includes subcutaneous fat, muscle wasting, ankle sacral edema, and ascites. Patients are classified into one of three classes. Class A, that is well nourished. Class B, moderate malnutrition. Class C, severe malnutrition. Studies have shown that class B and C is associated with more infectious complication, increased ICU stay, and increased hospital mortality. However, main limitation is that it was not developed for a critically ill patient and lacks certain variable relevant for critical illness like severity of illness. Also, there is component of subjectivity. Many nutritional assessment. Many nutritional assessment developed in 1994. It is one of the established nutrition screening and assessment tools to detect the malnutrition and the risk of developing undernutrition in elderly group. It consists of 18 components grouped into 4 components, which are self-perceived data, general status, dietary habits, self-perceived health, and nutritional status. Many nutritional assessment short form has been designed later to provide more practical tool in lieu of original MNA, which is time consuming for the screening purpose. So many nutritional short form consist of 6 items of earlier part of full many nutritional assessment. Now the malnutritional universal screening tool, that is MUS score, is commonly used for hospitalized patients. MUS score comprises the following variables, that is body mass index, unplanned weight loss in 3 to 6 months prior to admission, acute illness and nutritional intake in days prior to the admission. It was primarily developed for community and it had shown limited performance in critically ill patients. There are many other tools. These tools were developed and validated in outpatient or inpatient setting, but have not been validated in ICU setting. Now, nutritional screening in the intensive care unit. American Society of Parenteral and the Enteral Nutrition, that is ASPEN guidelines, define nutritional screening as a process to identify individual who is malnourished or who is at risk of malnutrition to determine if detailed nutrition assessment is indicated. Recent ASPEN guidelines suggest nutritional screening should be done in all patients admitted to the ICU within 48 hours to identify patients most likely to benefit from early nutrition therapy. Nutrition screening in the ICU patient is challenging because many of parameters such as accurate history of dietary intake, weight loss is difficult to obtain as most patients are on mechanical ventilation and sedation. Changes in the weight can be influenced by edema due to underlying disease and the large volume fluid resuscitation required to maintain hemodynamic stability. Therefore, muscle and the fat wasting evaluation becomes more difficult. Many of the nutritional tools available do not include inflammatory process and hypermetabolic status in ICU patients. All ICU patients do not respond similarly to artificial nutrition. Patients with high nutritional risk, they are at likely to benefit from early nutrition therapy. Therefore, there is a need to discriminate nutritional risk in critical care setting. In the ICU, acute and chronic starvation, inflammation, and the severity illness leading to ICU admission need to be considered. Severity of illness induces marked catabolic response, leading to 5% loss of lean body mass in single organ failure and almost 25% loss of lean body mass in multi-organ dysfunction syndrome in first 10 days after ICU admission. Nutritional risk means risk of developing complication and other adverse outcome which can be prevented by timely and adequate nutritional support. Nutritional risk is defined by assessing nutritional status at bedside baseline and the disease severity. They have an impact on outcome of the patient. Now, biological marker. Traditionally, serum protein markers like albumin, prealbumin, transferrin, retinol binding protein are used for screening and assessment of nutrition in the eyes. However, these are markers of acute phase response in the critically ill patient and is affected by increased vascular permeability status and hepatic function. So these markers cannot be used to represent nutrition status in the ICU setting. Now the next is anthropometric measurement like height, weight, BMI, mid-arm circumference, skin fold thickness were traditionally used to assess nutritional status. However, it is not reliable in assessing nutrition status or adequacy of the nutrition therapy in ICU as it is affected by non-nutritional factors like bedridden status and generalized edema. Now about inflammatory marker. Inflammatory markers like calcitonin, C-reactive protein, interleukin-1, TNF, interleukin-6, and citrulline are still investigation. They should not be used as surrogate marker. Validated tools are required to identify ICU patients who may benefit from nutritional support. Nutritional risk score, that is NRS 2002, and nutritional risk in critically ill Nutric score determine both nutritional status and disease severity. Patients at risk defined as NRS 2002 more than 3, those at high risk with score of more than or equal to 5, and modified Nutric score more than or equal to 5. The above scores are still not widely used and there is a lack of sufficient evidence. Improvement in the scoring system may increase their application and guide us regarding enteral nutrition and parenteral nutrition in the ICU. Society of Critical Care Medicine and Aspen Guideline 2016 recommended to determine of nutrition risk by NRS 2002 or Nutric score on all ICU patients whose intake is likely to be insufficient. Now, nutritional risk screening, that is NRS 2002. European Society of Parenteral and the Enteral Nutrition recommends the use of severity of illness in nutritional screening to identify risk. NRS 2002 is the new method based on analysis of controlled clinical trial. It consists of BMI, recent weight loss, recent decrease in food intake, and severity of illness. The total score ranges from the 0 to 6. A score of more than 3 is considered as a high risk. A score of more than or equal to 5, they are at high nutrition risk. And patient with the high nutrition risk, they are at more likely to benefit from early nutrition therapy. Now, nutrition risk in the critically ill score. Most of the nutritional screening method in hospitalized patients are cumbersome and time consuming. They are not routinely done. It is difficult to get accurate history of recent decreased oral intake and recent weight loss. BMI, CRP, PCT, weight loss, and oral intake were excluded in the Nutrix score because they were not significantly associated with mortality, or their inclusion did not improve the fit of the final model. Time in the hospital prior to the ICU stay was included in the Nutrix score and can be considered as a marker for recent reduced oral intake. As we know that in iatrogenic malnutrition occurs commonly in the hospitalized patient. The various measures of acute inflammation did not increase the fit of the model. CRP PCT did not increase the fit of the model and were not included in the final score. Interleukin 6 measurement have the logistical problem and are costly. Excluding interleukin 6 did not affect the score significantly. M-Nutrix score include the 5 variables, that is age, Apache 2, SOFA, comorbidities, delays from the hospital to the ICU stay. A score ranges from 0 to 9, and any score of more than or equal to 5 indicates high nutritional score. These scoring tools represent the first nutritional risk assessment tool developed and validated specifically for ICU patients and may help identify critically ill patients likely to benefit from aggressive nutritional therapy. M-Nutrix score is practical, easy to use tool based on the variable that are easy to obtain in the critical care setting. Now, the validation of nutrition risk in the critical score. De Veries et al. Found in the Dutch ICU that there was fair predictive performance of M-Nutrix score regarding 28-day mortality. The study concluded that M-Nutrix score is superior to the MUST score in prediction of 28-day mortality, and MUST score cannot be recommended for nutritional risk assessment in ICU setting. These results were similar to the original study by Heland et al. And subsequent studies of M-Nutrix score by the Rahman et al. And Mukhopadhyay et al. In Caucasian and Asian population. This study also showed that high nutritional adequacy was associated with reduction of 28-day mortality in patients with high M-Nutrix score. Mondel et al. Also validated M-Nutrix score in Portuguese ICU. Kotman et al. Compares the screening. He showed that traditional screening and assessment tool identifies different patients as malnourished and that at a nutritional risk in the ICU. Therefore, he concluded that traditional tool may be inappropriate for use in ICU. He also suggested that physical assessment, functional status, and severity of illness are objective and may be useful in screening and assessing nutrition risk in the ICU. In future, more research is needed to find out if any other objective parameters in nutrition screening process will affect outcome in the critically ill. The 3 studies in the Indian ICU have used SGA MUS score and recently M-Nutrix score for nutrition screening in the ICU. Feasibility of M-Nutrix score in Indian ICU has been demonstrated, and that should be preferred tool to assess nutrition risk in Indian ICUs. Thank you, guys.